Okay, so we're going to give 1 more minute so people can sit down. Cool. So now we have Rhys White from PHF Science. Rhys, the floor is yours.
Great, thanks, Ben. Hi, my name is Rhys, and today I'm going to be talking about some of the work that we've been doing at PHF in collaboration with a couple of diagnostic labs across the country. And before I start, I just need to point out that this is work that has been built off the backs of a lot of people, so it's a real honor for me to be here today and give you a small snapshot of what we've been able to do. And the title of my talk is Nā pūnaha, the systems, Nā tāngata, the people, and me nā hononga mō Aotearoa ināianei, which is the relationships for New Zealand now. So this is a little bit different to what I'm usually used to presenting. I think this is the first presentation I've given in 10 years that doesn't have a phylogenetic tree in. So what you're looking at here is a pattern that was clinically unusual but systemically invisible. Across April and May, multiple infants in the neonatal intensive care unit, or the NICU, developed a bloodstream infection, and it was caused by Klebsiella. On paper, these Klebsiella looked ordinary. They were fully susceptible to antibiotics. There was no alarming phenotype. And from the perspective of our national surveillance or our monitoring system, everything here was behaving exactly as it was designed to. There was no multi-drug resistance, no breach of escalating thresholds, no automatic trigger for the investigation, so the system essentially did nothing because, by its rules, nothing was wrong. The only thing that didn't fit was the context. Repeated invasive infections in a highly vulnerable population over a short period of time. So that signaled the pattern, the timing, and the setting is not something that our routine surveillance systems are built to detect. Our surveillance is optimized for resistance and recognized rarity, not for emerging clinical patterns. So this wasn't a failure of people. The system did exactly what it was designed to do, but it revealed a limitation in how we can define risk. So genomics entered this story not because resistance was detected, but because somebody recognized that the pattern itself mattered. At that point, genomics was the only tool that could answer key questions. Are these cases connected, or are they just coincidental? At this point, nothing in the system required action. Like I said, there was no resistance signal, no rule had been crossed, no algorithm telling anyone they had to escalate it. What changed the direction of this event wasn't the system, but it was the people. Clinicians, infection prevention and control staff, laboratory scientists, they all recognized that the pattern didn't fit the context. Repeat bloodstream infections in the neonatal intensive care unit are never routine, even when the organism looks ordinary. That judgment call is what triggered action, IPC involvement, a decision to do genome sequencing, and to have a closer look. And this all happened before the situation had time to declare itself an outbreak. Like I mentioned, we had only 4 sick babies in the NICU at the time. So genomics didn't replace any expertise here. It was used because the experts said we need to have another lens. And that's the gap that genomics currently fills. Not replacing systems, not replacing people, but extending what our systems can see and when people can recognize risks early. So what changed the direction here wasn't a new national program, and it wasn't routine surveillance suddenly working harder. What mattered was the connections. The hospital lab was already linked to a sequencing capability, and there was a clear, trusted pathway to escalate data to national expertise when it mattered most. And that connection didn't have to be invented in the moment. It already existed, and even if it wasn't formally designed as a system. So like I said, this wasn't national surveillance, and it wasn't routine sequencing. It was local action paired with national context, operating in a single system. Because sequencing was already where the samples were, and because the escalation pathway already existed, the timeline collapsed from weeks to days before the outbreak was able to fully declare itself. That's what no hononga looks like in practice, not technology in isolation, but capability positioned exactly where decisions need to be made. And once those connections were in place, the picture changed quite fast. Because sequencing was embedded locally, this wasn't a retrospective exercise. We were seeing events as they were unfolding, not weeks later. And because the right expertise was already connected to the data, interpretation of that data happened in near real time, not after the fact. Crucially, this allowed clinical isolates and environmental samples to be interpreted together rather than in isolation. And that alignment revealed something specific. These weren't unrelated cases, they shared a common genomic context. Sequencing corrected the initial species call and showed that these isolates belonged to the same lineage, shifting the focus from individual lineages and patients to the care environment. This wasn't about reconstructing who infected whom, but it was about recognizing that these events were connected in a way that our current routine systems hadn't been able to capture. And because that insight arrived early, the response could be targeted. It didn't disrupt the whole unit, there was no broader hospital disruption, there was targeted intervention, rapid containment, and minimal disruption to the NICU. And this worked, but only because the pieces were already aligned. What this NICU outbreak shows is not what genomics can do, but how contingent that success still is. So far, I've discussed what happened in one specific setting. What makes this example useful is that the signal was subtle, early, and clinically ambiguous, exactly the kind of scenario where current surveillance is most limited. This slide is about what examples tell us more broadly. So this isn't about replacing national surveillance. Like I said, our national systems are doing exactly what they're designed to do, and they remain essential. The question is much simpler. What would it take to extend coverage so that more epidemiological spaces become visible earlier? One part of this is being distributed. Sequencing capability needs to exist closer to where patients and samples already are. It doesn't have to be everywhere, but it needs to be in enough places that emergent signals don't have to wait for escalation before they can be examined. And the second part is all about being connected. Local sequencing only adds value if it can be interpreted in national contexts, with shared data, shared expertise, and integrated analyses rather than isolated results. And the third part is being context aware. That means triggers aren't limited to resistance or rarity, but can incorporate timing, setting, and pattern. So insight arrives early enough to support targeted response. This isn't a new surveillance system, it's a way of extending what we currently have across Aotearoa and a way of filling in the gaps, rather than rebuilding this whole structure. So up to now, the story sounds like a success, and honestly it truly is, but there is an uncomfortable truth that lies beneath it. This worked because people acted early, not because the system was designed to do so. Motivated individuals noticed that something didn't quite fit, and they knew who to call, and they were willing to escalate before formal thresholds could be crossed. Now, that's not a criticism of the system, and it's certainly not a criticism of the people involved. It's an acknowledgement of where the risk is currently sitting. Right now, early detections often inform factors. Right now, early detections often depend on informal factors. Who happens to be on shift, who recognizes the pattern, who has the confidence, the time, and the relationships in place to escalate. When that's the case, the risk is being carried by people rather than infrastructure, and that's not a sustainable national strategy. Goodwill doesn't scale. Institutional memory is fragile, and champions move roles, they burn out, or they can leave their roles. If success depends on exceptional individuals, compensating for missing infrastructure, then the system itself is brittle. The response here worked because the right connections already existed, but those connections weren't designed as a system. They were informal, relationship-based, and dependent on individual effort. The goal isn't more sequencing everywhere. It's reliable connections that have the same, that can behave the same way every time. This means sequencing capacity distributed close to patients, clear and shareable criteria for when something escalates, and routine trusted data flows between hospitals and reference centers. When those connections are designed deliberately, people don't have to compensate for the gaps. The system carries that risk instead, and that's what allows early detection to be dependable, equitable, and scalable rather than exceptional. So just to kind of bring everything together, I got ChatGTP to make this Te Kapenga, or the net, because what this outbreak really showed us, it wasn't a single failure or a single success. It showed how the system, the people, and the relationship have to work together if distributed bacterial genomics is going to protect patients in near real time. So the systems are the structure of the net, the pipelines, the sequencing, the triggers, and the data flow. When the mesh is tight, we can catch these risks early, before resistance emerges and before harm can occur. When the mesh is wide, things can slip through, and that's where today's system is currently struggling. The people are the ones who can cast the net, read and repair the net. The lab scientists, IPC teams, clinicians, bioinformaticians, the work only happened because skilled people noticed a pattern that the system wasn't designed to see. By relying on these exceptional people, it's not a sustainable strategy. And then the knots, the relationships, are where the strengths or the failure really lies. Trust built in advance, clear workflows, agreed data sharing and escalation pathways. When those knots are strong, the net holds. When they're missing, no amount of technology can save us. The key message here is this outbreak showed what's already possible in Aotearoa. The challenge now is not inventing something new, it's making this routine. If we want distributed bacterial whole genome sequencing to work at scale, we have to design systems that can detect risk early. So just to kind of finish, PHF Science is in a really good position to help this model, kind of a hub and spoke model, if you will. So we already kind of behave like New Zealand's National Health Security Hub. We can use advanced genomic surveillance to detect pathogens like MRSA or Klebsiella before they can spread and become larger outbreaks. We also have an active wastewater surveillance program for SARS-CoV-2 and poliovirus, which can be rapidly scaled up, including at the border, and that can be done when required. And what makes our approach unique is integration. We just don't look at hospitals in isolation. We can connect data from people, animals, wastewater, and the environment. And this system-wide surveillance gives us this early warning intelligence, not just for outbreak control, but for broader biosecurity and long-term resistance occurring across New Zealand. And like I said at the start, this work was based on a lot of effort from a lot of people, and I would like to thank everyone who has contributed to this work. A special shout out to Dr. Max Bloomfield. He's my clinical partner whose vision for implementing real-time genomics within the diagnostic hospital lab has been instrumental. And we're also grateful for Genomics Aotearoa for their funding support. And of course, this couldn't have been done with various teams across PHF Science and our Nui labs. Thank you for your time.
Any question for Rhys? Thank you very much. I might have just missed this. So I understand that they are related, but how are they? What is the physical relationship? Was it contamination from one incubator to the other? What was the physical process there?
So we don't quite have the data to be able to say whom gave it to whom. So I did put a reference on the slide for the paper, because this kind of talk is quite different to what I'm used to giving. I'm used to talking about phylogenetics and SNPs and everything like that. So what happened was those 4 initial cases triggered the outbreak investigation. So the IPC team went in and did skin sampling, like just swabs of the babies, and also sink trap sampling in the NICU as well. So we found the same organism, Klebsiella varicola. It was initially mis-ID'd based on phenotype, so it was Klebsiella pneumoniae, they thought. So yeah, we found those 4 babies with the same multi-locus sequence type. They differed by minimal core genome SNPs, and yeah, had the exact same plasmid that they were carrying, and that was across those 6 infants and 2 sink traps in the NICU. But we don't know if they got it from the sink or if the sink became contaminated. We don't have that data.
But is there a temporal sequence in those babies? I mean, were they all at the same time? Or was one after the other?
Yeah, it kind of popped up within the same week, those 4 bloodstream infections, and that's what triggered the IPC nurse to see the doctor and go, oh, this has happened and it's unusual. And if that conversation didn't happen in the hallway, they wouldn't have looked at it, because surveillance is targeting specific antibiotic-resistant organisms.